Hi, we're going to talk about stroke. At the end of this, I hope you have a better understanding of stroke. Specifically, what are the major risk factors? What does the patient experience in general when a stroke is occurring? What would you expect to see as the nurse? What are you going to do as the nurse? How does this tie into the overall concept of perfusion? So follow along and let's get started. Remember, we've talked about what perfusion actually is, and it's simply the process of getting blood or other fluid pushed through a vessel and into the vascular bed of the tissue. It's bringing in oxygen and nutrients, and then it's taking out the trash, picking up the unoxygenated blood and carrying it back to the heart. And remember, we talked about some of the elements that were required for normal perfusion. And of those, adequate blood volume and components is probably off. There's a chance adequate cardiac output is off. Maybe intact coronary circulation and systemic circulation are impaired, and adequate tissue uptake of oxygen. All these factors can be altered, and that may be part of the etiology of the stroke. So what is a stroke actually? It's described as a sudden decrease in blood flow to an area of the brain. It can be ischemic, which is when a clot is busting through. And remember, we've talked about atherosclerosis and plaque in the arteries, and that's just a breeding ground for a piece of that to break off and travel and become a thrombus. Okay, and then what's going to happen is ischemia. Ischemia is simply a restriction in blood supply to tissues caused by constriction or obstruction of blood vessels. So basically, we're not getting enough oxygen-rich blood to the brain. And remember, the brain is a diva. In fact, the brain, even though it only makes up 2% of the body weight, the brain requires about 20% of the cardiac output each minute, which is about 750 milliliters. And it also accounts for about 20% of the body's oxygen consumption. So a clot partially or completely obstructing that pathway when the brain has such huge demands for oxygen and blood, you can see why it would cause some significant problems. We want to keep it flowing. We want to get that brain some oxygen-rich blood. So there are some things that can be done for patients who present for care early, within hours of onset of symptoms, and the standard is 3 hours of LSN, last seen normal, for people to be eligible for thrombolysis or administration of TPA, which is colloquially known as the clot buster. What it does is breaks down the fibrin, and that degrades the thrombus. Again, the time is 3 hours, but the American Stroke Association modified that to 4.5 hours for people unless they fall into these categories. If they're older than 80, or if they're anticoagulated with INR less than or equal to 1.7, a baseline NIH health stroke scale is greater than 25, or if they have a history of both stroke and diabetes. And the definitive diagnosis, the gold standard, is still a non-contrast CT of the brain, or CT of the head, CAT scan. And you don't need contrast, because if it's a hemorrhagic stroke, the blood is the contrast. So once that's been established, it's a stroke, they meet the criteria, you can give the TPA. The nursing actions for that is you're going to observe the patient closely, you're going to check their neuro status, and remember bleeding precautions. You know, you're giving them a clot buster, so they're at risk for a bleed. And this is why it's also important to be sure they haven't had any head trauma within the past few months, that they haven't been in a car wreck, or within the past few weeks they haven't had blood in their urine or stool, or a surgical procedure. Among the actions we're going to take to protect the patient, we're going to be particularly alert for symptoms of increased intracranial pressure. We're going to report any deterioration in their neurological status immediately. Remember, the first sign of increased intracranial pressure is a declining level of consciousness. We're going to keep the head of the bed elevated 25 to 30 degrees. Not only does that help prevent a decreased blood flow to the brain, but it also is a good aspiration precaution, because a lot of these patients are going to have swallowing difficulties. They may have an impaired level or a lower level of consciousness, so they are at tremendous risk for aspiration. So you're going to maintain their airway, and just keep in mind that aspiration is a very big risk for them. Remember, one of our goals is we want to keep the patient from losing more function, and we also want to help them as much as they can get back to where we were. Remember, they often have flaccid or spastic paralysis. It's not unusual for them to eventually end up with a flaccid arm or spastic leg on the affected side, because the affected leg often regains function more quickly than the arm. As soon as possible, patients begin rehab so that they can regain function and prevent complications of immobility. Don't forget, no matter what the cause, no matter why you're immobile, if you're immobile, you're at risk for pneumonia, atelectasis, pressure ulcers, DVT. And DVT is a huge risk here with their impaired mobility. So they're going to get DVT prophylaxis. This is highest in older patients with a severe stroke. We're either going to use TED hose, which is the trade name for compression stockings. Not trade name, brand name. It's sort of like, how everybody calls a facial tissue a Kleenex. Everybody calls compression stockings TED hose. Or sequential pneumatic boots. We're going to frequently change the patient's position, and we're going to ambulate with assistance if possible. Depending on where the brain was injured, you can expect that there may be some communications problems. There may be problems understanding, like the patient understands exactly what you're saying, but their speech is garbled, or they can't make themselves say the words that they're hearing in their brain. They understand you just fine, and they know what the proper response is, but now they're unable to get that out and get that into words. They may have bowel and bladder incontinence, so we're going to have to start a retraining program, and you do that. You just have them, you offer a bedpan or offer opportunity to toilet on a set schedule, and get them back into that habit. And unilateral body neglect, that's most common in patients who've had a right cerebral stroke, and this problem places the patient at additional risk for injury, because there's an inability to recognize their physical impairment, because they have a lack of proprioception. And I'm not sure I pronounced that right, so I'll spell it PROPRIOCEPTION, which is position sense. And these patients they're at risk for depression. It's frustrating for them. It can be frustrating for their family members. So our goal is to restore and maintain as much as possible so that the patient can live as full a life as possible. I'll beg your forgiveness in this section. I've always had trouble pronouncing these words, and I'm not so convinced I'll say them right today. So let's look up in column 1, proprioception. It's the body's sense of its own position. Think about when you're standing, and you sort of get a sense of where you are on the ground. You can feel the ground through your feet. You sort of sense the presence of others, and it keeps you from brushing into everybody. You know your position, and you know where you are in the world. Many of these patients can no longer perceive or sense where they are in relation to other things, or that part of their body. Hemianopia is loss of half the visual field in one or both eyes, and homogeneous hemianopia. Boy, that's a mouthful. It's when the same half is missing in each eye, and I'll show you a picture of that in just a minute. But these visual changes are important because if you're trying to provide care, you need to understand where their deficit is, and the patient may or may not be aware that they have this deficit. So you need to understand where their stroke occurred, what part of the brain was damaged, and plan your care around that, because you don't want to be standing in their blind spot. You don't want to set up their meal tray or their toothbrush or do their rehab when you're standing in their blind spot. This chart is from the United Kingdom, the Department for Work and Pensions website, and it's available for the public use. And there's not really much for me to say about this. I'm just going to be quiet for a few seconds, or you can pause it if you need more time to look at it, and this will help you figure out where the visual deficits are for your patient. And in a moment I'll also show you a photograph that may help give you a clearer picture. This will give you an idea of how the world looks to this person. And if you just pause this screen for a minute and just sit and look at it, I think it'll help you understand what their deficit is and what we need to do to help keep this patient safe, and to teach them how to compensate for this so that when they do go home they can have as much quality of life as possible. I believe we've answered this question, but we need to care about visual changes because the patient is frightened. We want to be where they can see us. We want to help them understand what's different, how to overcome that, not lose any other function, and we need to know where the stroke was, what part of the brain has the lesion. We need to know what functions are impacted by that so we can provide the best care possible to these patients. I wanted to make a quick mention of some of the other sensory deficits. The first one here, inability to recognize one or more subjects that were previously familiar. That could be someone who had been a computer engineer her whole life, and now you sit her in front of the computer and she has no idea what it is. This can be visual, tactile, or auditory. Apraxia is the inability to carry out some motor pattern like drawing a figure or getting dressed. We have enough strength and coordination. Remember, this is not a muscular problem. This is a neurological problem. There's a breakdown in the pathway from the brain issuing the command to that muscle or whatever to move. I think these changes are fairly self-evident, but I did want to talk a little bit about the emotional ups and downs. The patient could laugh or cry easily, could be irritable, demanding, depressed, confused, but the nurse needs to let the family know that the patient's laughter does not necessarily mean they're happy, and crying doesn't necessarily mean they're sad, that this may improve with time. And normally with your therapeutic communications you would try to say, well, how do you feel about that, and so on and so forth. But in this case you just distract them, because remember, this is a neurological problem, this is a flow problem, and this is something that's different after the stroke. Decreased tolerance for stress. We need to keep a low stress environment and make things as simple as possible for these patients. And just remember too, they may pop out cursing or something, and it's just part of the stroke. They don't mean it, and they're not trying to be hurtful. I believe we've covered these complications pretty well: communication, motor deficits, elimination issues. Just be aware that these can happen, are going to happen, and we want to help restore. Okay, let's do a couple review questions and see if you're catching on to stroke. I think the best way to do this section is for you to read the question and then just pause it until you're ready to move to the next one. I hope you found this useful and that it's helped you. I will post these answers in a separate document.